Okay, let's go ahead and get started, at least some. Um, Questions from class on Monday. Okay, how's the zombie assignment going? You already have it done. Your part or the whole thing? All righty. All right. Good. Good. I'm glad you think so. Well, then that's all you say. Yeah. So what did you find that was the product? Tetrodotoxin. Yeah.
I found that it's certified people in Japan are the only ones that cook them from October to March.
Right. Yeah, they're really nasty little critters. But in Japan, the sushi that's made from the pufferfish is considered a delicacy. And there's this sort of pseudo macho thing about eating them. You're taking a risk. And what you're betting on is the skill of the chef. A bet that I probably would not be willing to take up. Yeah. Hmm. Yeah, but people will do it anyway, and people die from it every year. Yeah. Yeah. I used to go to Japan a lot, and I used to eat sushi, but I'd never touch a pufferfish. Um, that's right. That's right. So tetrodotoxin. In general, it's fatal. If, again, properly prepared, then, it's like eating any other fish. But yeah, it's a really nasty toxin. I think the Japanese were trying to work on some sort of rescue, but I don't know where it went. I haven't paid attention since I don't go to Japan anymore. I haven't paid much attention to that topic. So, okay. So you finished that. Okay. Well, okay, the interpretation is going down and looking at the total, add up all the positive and negative numbers, look at the total, and look at what that risk is from the risk chart, the very last of them. That's the interpretation. That you have a, slightly elevated risk. I mean, or maybe even a significantly elevated risk. I don't know. I haven't seen the profile yet. So, but that's the interpretation. And so then there's the issue of what would you advise the patient to do to lower their risk? Usually it's pretty obvious. Pardon? Well, there's that. Stop smoking is another one if they smoke. Um, we've correlated these things pretty well. There's still some minor debate about, maybe not even terribly minor, about the role of cholesterol. And there's some rethinking on some of it. But because we're learning it's a much more complex system. And of course, we need cholesterol. You can't just you can't just cut it out of your diet.
Yeah.
And in fact, you can cut it out of your diet because actually the liver makes enough cholesterol for the body's needs. So the issue is, I think the issue of dietary cholesterol is more related to the issue of diet in general, and perhaps that the guidelines need to be re-examined. And it's kind of hard to know what to say about that particular topic. The correlations are there, but in statistics, we learn that just because something happens at the same time doesn't mean there's a cause associated. One of the best examples that we use in the I use in the statistics class here is that if you look at the price of a slice of pizza and subway fares in New York, they seem to be, they rise exactly at the same rate. And so what we use that as an example of, subway fares don't increase the price of pizza and vice versa. So what's actually going on? So you look for something else that both of them may be influenced by. And in this case, it's the consumer price index. That's another thing. Now, to say that the consumer price index causes anything is a total misunderstanding because it's merely a measure. But it's the inflationary pressure in general that drives both of those up. And we have to be very, very careful about that. And that's why I say, don't overinterpret these things. Don't look at them and say, oh, you're going to die. It's the risk of heart attack or major cardiovascular event over a 10-year span. And if there's and it sounds pretty significant. What's an increase of 26% mean? Well, it doesn't mean you have a 26% chance of having a heart attack. What it means is that compared to a baseline, the number of people with your profile who have heart attacks in that 10-year span is 26% larger, but we don't necessarily know what the baseline is. If we're talking about 26% more than 2%, then that's different than 26% more than, say, 20%. So, it's really, you have to be very careful with not to overinterpret these things.
Yeah.
So, all right. We'll give Glennis a few more minutes. I have a suspicion that Sarai might not be coming in because she's usually here by now. And I haven't heard from her. Okay. Okay, thank you. I'm sorry?
I'll message Glennis and see where she's at.
Okay, thank you. So today we're going to talk about pain, the pharmacology of pain, and how we deal with it. And some things that we'll talk about will include some recent data on the use of painkillers and some of the problems we're facing with painkillers in the society at the moment. We'll, as I said, if you hear from Glennis, let me know. If she's close by, we'll wait. If she's not, we may just start to continue. Near Timnath, okay. All right. So she's still a bit away, so we're going to have to go ahead and start. Let me give you that. Okay, so we're going to talk about the pharmacology of pain first, but again, a quick, on the handout I just gave you, a very quick review looks at the parasympathetic and sympathetic nervous system, which is part of the peripheral nervous system, of course. And what we have is a picture of the relationship between the spinal cord and the somatic motor neuron and the autonomic motor neuron. Remember, the somatic system is our voluntary system, and the autonomic system is our involuntary system. Pain is a part of our body that lets us know that something is wrong. Pain itself is a difficult topic. Long periods of time, we've debated about what pain really is, and now we look at it more as a perception instead of an actual physiological state. And it has, because it's as much psychological as anything else. We've all known people with very high pain tolerance, and we've known other people that stub a toe and act like they've just been killed. You know, it all depends on your reaction. There are lots of examples of people who apparently can ignore pain. And in fact, you can to a great extent. However, pain does interfere with our lives. Pain is something that occurs on injury, but it also occurs as a result of physiological changes that we experience as we get older. We lose the protection. Sometimes the myelin sheath on the nerves is a little compromised. Sometimes you have pressure on nerves from degenerative, say, spinal disease, arthritis, and other pains as well. Pain associated with certain diseases such as cancer, or as you're experiencing now with ovarian cysts, we can look at the cause there and say, well, this is what's causing the pain. But the response to pain is always subjective. There are people who can put up with huge levels of pain. Our pain scale, you've probably heard the 1 to 10 pain scale. Yeah, with 10 being the worst and 1 being, basically pain-free. And most of the time, I think most of us would say we're about a 1. But we start feeling pain as a result of various things. And the question about pain that is asked is, what is your level of pain? And people misdefine this quite a bit. Some people think, I've heard people ask the question, what is your level of pain, with 10 being the worst pain you can imagine and 1 being basically no pain. That's the wrong question. 10 ought to be the worst pain you've ever felt. Because my wife had a patient one time who was obviously in pain. You could tell from her reactions, you could see it in her face. And people who are in chronic pain you can see that they're in pain. Their eyes, they look like they're exhausted because you can't sleep through it. There's a lot going on that pain interferes with. So she had a patient that was obviously in pretty significant pain. And when she was asked what her pain was on a scale of 1 to 10, she said, about a 3. And so when my wife started questioning her, well, the doctor said it was the worst pain imaginable. And the worst pain I can think of is somebody sawing off my arm with a butter knife. Okay, that's ridiculous. And that's a bit of an extreme, but when Susan recharacterized the definition as the worst she'd ever felt, now it came out to be like a 9. And so the doctor was listening to her 3 and not prescribing any painkillers. And that, to me, is a total, misuse of that scale. Most people have now come to the realization that the real question is 10 is the worst you've ever felt. So that scale is going to change throughout your life, because there are going to be times when you're going to really hurt. And there are going to be other times when, you hurt in a way that's like a 10 if you ask that question to a 6-year-old who'd never really been hurt, right? Worst pain you ever felt. Well, gee, that's what I feel now. So it must be a 10. But when he's 15, he might say, that's more like a 3 or a 4, because he's been hurt worse. So the issue is to try and frame this in a way that has some meaning to it, because pain is experienced differently by everyone, because it's a perception and a very much a subjective response. You have to be careful when you try to determine what level of pain a patient has, and then treat accordingly. The issue with pain is difficult to define, because, of course, there's no real objective scale of measurement. We can't hook you up to a machine and say, your pain has to be a 6. We can't do that. There is no objective measure. And therefore, we need to be looking at what pain is. And it's various definitions have been applied to pain. The one we use here is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. Okay, well, potential tissue damage? Again, the perception. And the issue is going to be how do we deal with that? Um, it's a physical discomfort. Okay, we all have those. There's lots of physical discomforts in this world, but pain is a special one. Um, there are the sensation itself comes from a very complex set of chemical stimuli, chemical changes, but it's all interpreted by the brain, just like everything else. The vibrations in the air that our ear receives, our brain interprets as a sound we can recognize, or maybe a sound we don't recognize, but it is interpreted that way. So it's the same with pain, and pain ranges. Pain is also a part of our immune system, in a way, in that if you get cut and it hurts, that's your immune system too. That's your body telling you, go take care of this before it gets any worse. So you go clean it up. If you have to, you put a bandage on it. If you really have to, you go to the doctor's office and maybe even get stitched up. But the issue is our body is warning us that something isn't right. And so pain, and of course, pain can also occur in things that are normal, like the most obvious is childbirth. Okay? It's interesting to me that the body doesn't produce something to ameliorate that pain because, of course, it's a natural process. It's one that we need in order for the race to continue. So that part of it has always mystified me as to why there's no sort of internal analgesic. But the part of it has to do with the issue of a class of molecules known as prostaglandins. These are important mediators of a lot of functions within the body. They can stimulate all sorts of things, including responses we interpret as pain. They are key to the inflammatory cascade, and many of our common non-steroidal anti-inflammatory drugs work by inhibition of that cascade of events that create the prostaglandins. Aspirin is an example. It interferes with prostaglandin chemistry, and by interfering with an enzyme known as cyclooxygenase, which forms the nuclear head of the prostaglandin family of molecules. This was not known. Aspirin worked. Aspirin was discovered in the 1870s and works real well. But no one knew how it worked until the 1980s, over 100 years later. But because it took understanding understanding biochemistry, but understanding what goes on in the human body and these molecules that are produced in very small amounts. They're extremely potent molecules, and so they're produced in small amounts. And we didn't have the tools to even know that they were there until the late 60s, early 70s. And then, as is normal in biochemistry, they were more of a curiosity at first. And then people began to study their effects and discovered that they have a wide variety. They were originally isolated from the prostate, which is why they were called prostaglandins. but they're all over the body. They're actually made in a wide variety of tissues. I think there's a fairly high concentration of them in prostate, and I think that the discovery probably came from looking at surgically removed prostate from various, not just from humans, but from others as well. So these things weren't even known. Weren't even known to exist until the late 60s, early 70s. And then it took a lot more research in understanding how they're synthesized to discover that aspirin actually inhibits them, and that's how aspirin does its anti-inflammatory activity. So that got a couple of people the Nobel Prize for that discovery, because it opened up a whole realm of potential. It also opened up something that was sort of a Pandora's box. Remember the story of Pandora's box? Yeah, so Pandora's box, in that when we discovered that aspirin worked by inhibiting cyclooxygenase, and then we discovered that there are actually two different versions of cyclooxygenase, 1 and 2, real imaginative names. We started looking, the number of companies started looking at the cyclooxygenase 2 inhibitors. And a whole series of those got marketed as pain relievers. They were touted as being, much better pain relievers and blah, 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 blah. And then we found out they were pretty darn toxic. And all but one was taken off the market real fast. The FDA basically said, you better pull these products because they're too dangerous. And the companies realized that too. And only one of them was on the market for a long time, and that one's recently been withdrawn. So we don't have any more of those because it turned out that was not a good. Hello, Glennis. You're here. Yeah. So where do you actually live? Oh, okay. Okay. Okay, that can be a fair schlep at certain times of the day. Yeah. Yeah, that's a trip. Okay, we're talking about pain. So you have a couple of handouts there. We're talking about pain today. We're going to go through talking about pain and some of the issues surrounding pain, and especially some of the issues around current issues around opiates and opioid compounds. But we're talking about now a series of molecules that are released when under variety of conditions in the body that actually stimulate nerves, and in some cases that stimulation is interpreted as pain. I made the point that pain is a subjective issue. Everybody feels it differently. It's more of a perception issue, because some people are much more pain tolerant than others. And we talk about pain as though it has some well-defined characteristics, and it really doesn't, because everybody feels it differently, and everybody responds to it differently. People who are in chronic pain are different than people who are in acute pain. Acute pain is, stubbing your toe or breaking your arm or something like that. That's something that is short term. People with chronic pain, arthritis patients, cancer patients, people with spinal injuries, people with degenerative nerve conditions that result in a lot of pain, that changes their chemistry. And we'll talk about that too, the difference between chronic pain and acute pain. Pain is also part of our immune system in that it's a warning. You cut yourself, you hurt. It's painful. That's telling you, go clean this up. You know, because we know that if you that we don't want infection as a part of an injury. So there are lots of things that go on. The process of pain includes a series of molecules called prostaglandins. And prostaglandins are inflammatory mediators as well. Come on in, Amanda.
Happy spring. Welcome.
You're welcome. Thank you, Amanda. And these inflammatory mediators are one of the aspects of how things like aspirin and ibuprofen work by inhibiting these things. There's another one called protein C, or substance P rather, and they are released by what's known as the C fibers in the nervous system. Okay, generally associated with persistent and chronic pain, sometimes with intense pain. They can be inhibited by the opioids. That's one of the mechanisms of opioid activity, or by norepinephrine or serotonin. They're generally used these fibers and the process of the pain signal, which of course is only interpreted in the brain, and is part of that mechanism. So we have acute pain, sudden. Usually it is a signal that we need to do something to help ourselves, fix something, and usually fairly quickly after that, once we deal with it, it subsides. There also is a couple of things about pain, and one of them is one of the things that that we have to understand. There are two kinds of sensory sensory structures that we can by which we perceive sensation. One of them is the pain, and that's something that is these C fibers. The other is pressure. Have you ever noticed that if you cut yourself or hurt yourself, if you put pressure on it, it stops hurting? Well, that's because the pressure sensation overcomes the pain sensation. Okay? And it really is a way of physically overpowering that sensation that's going. So that's what the brain interprets as being the primary signal, is that pressure. And that's one of the reasons that that when I teach our class in injections, Pharmacy 107, I teach people to activate those pressure sensors in the skin to greatly reduce the pain response to shoving a piece of cold steel into the skin. And that works pretty well. If it's done right, and if the person knows what they're doing, the actual poke of an injection will not have any sensation whatsoever, at least as far as the brain is concerned. Does that mean that there's nothing that happens to the pain sensors? No, but if you properly prepare the patient, then you've already overcome that. But the thing about acute pain is it comes on, you deal with the issue, and then it's gone. Sometimes that gone could be within minutes, and sometimes gone could be a couple of days for a major injury like a broken arm or something like that. But usually it goes away. Chronic pain, and it usually is fairly easy to treat with short-term agents like non-steroidal anti-inflammatories. Chronic pain is much different. It's persistent or it's recurring. Things like diseases like MS and other diseases that have exacerbations and remission, then the pain is coming and going. But the problem with all of that is it's very difficult to treat, and very hard for people to live with. In terms of the classification of pain, really, as you probably already know, not all pain is the same. There is what we call somatic pain, which is something that is basically skin and deep tissues. There's visceral pain, which is our internal organs. Superficial pain, which is basically what we feel when we cut our finger. There can be vascular pain that comes from a disruption in blood supply. And a prime example comes out of cardiovascular system, angina, which is the pain that occurs when oxygen flow is cut off to or reduced to the heart. Referred pain, that's when you feel something in one place, but the cause comes from someplace else. This is very, very common. And it has to do with the way the nervous system is structured and how the brain interprets pain. Neuropathic pain is the consistent pain that we see when with degenerative disease or pressure on a nerve, such as a ruptured disc in our back, causing pressure on the spinal column. That's neuropathic pain. Phantom pain is common in amputees. Our pain receptors are all over, but it's not unusual for a person who might be missing an arm to actually feel pain in the hand that was at the end of that arm. And that's because the brain is interpreting its signal as coming from there, even though that's impossible since it isn't there. Cancer pain, this is again something that's more likely related to the inflammatory component of cancer. Cancer is not just a rapid tissue growth disease, but also it results in an inflammatory response. And we already know that inflammation generates these substances that give us the sensation of pain. Psychogenic pain is a generalized term that refers to pain that has no obvious cause. People talk about, they're in pain because their long-term companion dog died. Well, they don't actually physically have pain, but what they're interpreting, their reaction is painful. And then central pain, which has a lot to do with sensations arising from the CNS. Um, we classify it uh, by the source. Vascular pain, um, again, possibly. We call, pain is such a difficult topic. A lot of research is done. We have lots and lots of data, but most of the data have led us to theories rather than real understanding. And vascular pain is one of those, arising from the vascular tissues, or what we call the perivascular tissues, which are those things that are around it. Neuropathic, injury to peripheral nerve fibers or direct damage to the CNS. Superficial, skin, mucous membranes. Picture here in the slideshow shows a diabetic foot ulcer. They're very painful. So we have a couple of other types, what we call nociceptive pain, which comes from activation of the sensory receptors by some form of stimulus. That stimulus can be mechanical. In this case, it could be somebody poking a hole in your skin, or it could be somebody punching you in the nose, or it comes from chemicals. I mean, you've probably, well, I don't know, maybe you have, maybe you haven't. I'm a chemist by education, and so there have been times when I've spilled nasty chemicals on my skin, and it's painful because it burns away the skin. It causes a problem. Basically, this is something we all experience whenever we cut ourselves. That's all nociceptive pain. Neuropathic pain comes from damage to our various nervous systems, either the central or peripheral system, or from an altered processing of the pain signals by the CNS. And this can be as a result of injury, or it can be as a result of chemical changes in the brain, which can be induced by some medications, by some drugs, illicit drugs, or by some natural process in the brain. I mentioned the idea that there are two kinds of pain of sensory receptors. That comes out of something called the gate theory of pain. Uses this analogy of a gate to describe the difference between these different kinds of insults or impulses from the tissue. Function of a information traveling into the spinal cord through large and small nerves. Large nerves carry non-nociceptive information. Remember, nociceptive information is the acute pain from an immediate chemical or mechanical damage. So that would be like the poke of a needle if we're getting an injection. That's nociceptive pain. If, however, we activate the large nerve fibers, the non-nociceptive nerve fibers, and one way to do that is to actually put pressure on the tissue around the site that you're about to poke someone. Takes about 2 seconds extra to do this. And what you've done now is the large nerve fibers, if there's more activity from those nerve fibers, the non-nociceptive, then in the small fibers, the nociceptive that come from the nociceptive receptors, then you won't feel the injection. And that's really something to be aware of as you move into the medical field, that you can make things easy on your patients or you can make them harder on your patients. The obvious thing, obvious corollary to that is if the small nerve fibers, the nociceptive fibers, have a higher signal rate than the large fibers, then you're going to feel pain. Okay. So that is the idea of the gate theory of pain. So we have two types of nerves. We call them small fibers and large fibers, but it really depends on where they're coming from. And then types of pain that we feel are related to the proportion of large and small fibers in damaged areas. If you've ever had a surgery and have had a drain installed in the surgery site, and a drain really is just a conduit placed in the surgery site to allow excess fluid that's built up as a response to the surgery to drain out. When that's withdrawn, you feel nothing. Actually, you might feel just a little tickling sensation, because the areas that they're implanted don't have the small fibers. And if it's withdrawn with a little bit of care, you won't even get any signal from the actual exit site, which is going to be on your surface where there are small fibers. So we have a lot of different kinds of our sensory types of neurons. The large fibers are both motor and sensory, and they're myelinated, meaning they have that sheath of fatty material that actually cushion the nerve and protect it from unwanted stimuli. As we get smaller and smaller, we start getting to thinly myelinated and unmyelinated nerves, and these are the ones that for the sensory are responsible for our perception of temperature and of pain, vibration, touch, etc. And the unmyelinated and very thinly myelinated neurons in the autonomic system are what control all of the other functions, all of the autonomic functions of our body. It's now at a time, let's take our first break. It's almost 20 till. So, all righty. So pain, again, remember we talked about the gate theory of pain. You have large and small muscle fibers. Basically, that means the difference between myelinated and demyelinated, or reduced myelination on those fibers. The one way to control pain is somehow to shut the gate, stop the pain from getting through. And the body does. I was talking to Cheyenne before you came in, Glennis, and saying that the body, pain is a warning, but there are some functions of the body that pain is a natural consequence, like childbirth. And so why doesn't the body produce something that actually effectively blocks that? Well, the body does have endogenous molecules, endorphins, that do bind to the opioid receptor and inhibit transmission of pain by closing that gate. It's just that they're not that efficient, and to be able to stop the kinds of pain that we sometimes have to deal with. Obviously, we talked about the fact that if you've cut yourself, if you put pressure on it or rub it, it stimulates the large sensory fibers and again closes the gate. And so you don't have you reduce the recognition of pain. It's not that you don't ever feel it, but you do reduce the recognition and the sensation that actually disturbs you with that. Analgesics are the medications that we use to relieve pain without causing loss of consciousness or interfering with the actual actions of our sensory nerves. What we interfere with analgesics is that gate with the signal that gets through. The actual actions of the nerves are still going on. It's just the brain isn't recognizing what's happening. These are as opposed to anesthetics, which basically cause you to lose consciousness. This does not mean that your systems don't work. It does not mean that your eyes, your ears, and other sensory organs aren't working. It's just that the brain is not processing those signals as on a real-time basis. So the analgesics fall into a couple of categories, which is pain, actually interfering with the transmission of pain, and reducing inflammation. We talked about inflammation. That's one of the pathways, the prostaglandin pathway of pain, and it is so if we reduce that production of inflammatory mediators, we can reduce the sensation of pain, or we can mess around with the gates. As a general rule, we manage this by interfering with the ability of the CNS to process the information one way or another. The anesthetics come into two classes. One is general. In other words, they depress the sensation, the ability of the CNS to process sensory impulses from throughout the body, and they cause unconsciousness. Most of our major surgical processes, in other words, anything that involves a significant invasion of the body, are done under general anesthesia. Local anesthesia is used to stop, again, to interfere with nerve conduction at the site. So that's why you might get a lidocaine injection if you go to the dermatologist and have them do a biopsy of a patch of skin that they're suspicious about. They actually will use a surgical tool to cut that skin out of your body, and then but they give you a local anesthetic, usually lidocaine, but a local anesthetic to interfere with the ability of the nerves in that area to respond. Those are all of our cane anesthetic, lidocaine, and benzocaine, and others. Some of these are topical, some of these are injectable. And one of the things that we teach is ways of injecting some of these small these cane molecules for local anesthesia. Most common pain relievers are the class that we call non-steroidal anti-inflammatory drugs. Now, this includes aspirin and ibuprofen. Acetaminophen, also known as Tylenol, is often sort of lumped in with these, but it is not a non-steroidal anti-inflammatory drug because it has no anti-inflammatory action. So it can be used for fever reduction, and it can be used for pain, but not for reduction of inflammation. They work by, we talked about this before, interfering with the biosynthesis of the prostaglandins. So they interfere in that stream of the biological processes. And aspirin and ibuprofen are the prototypical ones. Lots and lots of other non-steroidal anti-inflammatory drugs have been synthesized and tested and marketed, but the ones that we use for the most part are aspirin and ibuprofen because they're both over the counter. Many of the others that are available are not over the counter, or they're used in much smaller amounts. Naproxen, for example, is now available over the counter, but most people don't go there. Again, the difference here is they have three different kinds of activity: analgesia, relief of pain. Remember, algesia is pain. An means no, so it inhibits pain. Anti-inflammatories and antipyretics. Antipyretics are things that are fever reducers. Pyresis is an elevation, general body temperature elevation. Acetaminophen doesn't really fall into that class because it doesn't have the anti-inflammatory activity. We have a number of these things that have been marketed. They're really used as well for their activity at reducing the stickiness of platelets, and so reducing thrombus formation in the body. Aspirin is the best of these for that. Aspirin, of course, we know we don't use in small children. Now we're starting to wonder about other populations. Aspirin itself is a relatively safe drug. It does have an issue with you must take it with either as an enteric coated product, in other words, one that doesn't release in the stomach but gets through the stomach and releases in the small bowel, or take it with food. Huge amounts of these drugs are consumed. All you have to do is look at the number of bottles of these drugs that are on the shelf in any pharmacy, and you know that huge amounts of these things are consumed every year. We also have some of the cyclooxygenase, or COX or COX, cyclooxygenase inhibitors. But although a number of those were originally developed, they're no longer marketed because they have a number of side effects that have caused them to fall into disuse. We have ibuprofen and naproxen, Motrin, Advil, or ibuprofen, or the multiple ibuprofen generics. Aleve is naproxen, and it too works much the same way, but it has never, it had, as a prescription only drug, it never had a lot of, there were some restrictions on its use. It never got as popular as Motrin and Advil. So it never had the market that they did. Indomethacin is a drug that is old. It's an old non-steroidal anti-inflammatory. As far as I know, it still is not over the counter. I said as far as I know. I haven't been monitoring that. A few years ago, there were a whole lot of drugs I said would never be over the counter, and they all are now. So I've stopped saying that. But we do have these as prescription drugs that are used for treating certain types of arthritis and other inflammatory conditions. Diclofenac, Voltaren, there are a whole family of the Fenacs, but diclofenac is the one that's most likely to be used in this country. Again, it's a prescription-only drug and is used in doses that are significant to treat diseases like some of the real heavy inflammatory conditions that people have. Aspirin, low to moderate pain. It's used for an awful lot of things. Right now, many people are taking low-dose aspirin as a way of reducing the likelihood of stroke and myocardial infarction. The data, everybody takes the 81 milligram form, but the data that I've seen indicates that you get the same effect from taking a full aspirin, 325 milligrams. Now, so why wouldn't you take 81 if you're going to get the same effect? The only reason that I generally think any drug, if you can take a lower dose and get the effect, that's what you should do. The problem is the 81 milligram aspirins cost a lot more than a full aspirin. So if you're looking at a cost effectiveness, it's cheaper to take a full aspirin because they are much, I've compared the prices. The price of these baby aspirins, which of course are not given to babies, this price of the baby aspirin is significantly higher than buying a full strength tablet. So if money's an issue, people should probably take it. The real issue is that aspirin is a gastric irritant. The baby aspirins, one of the reasons that most of them are so expensive is they're all enteric coated. And enteric coating is another manufacturing step which adds to the expense. You can get enteric coated full strength aspirin, which I think people should use. It also is more expensive than just plain old aspirin. But the difference is that it's still cheaper per tablet than the baby aspirins. We don't use aspirin in children under 12. So there really isn't anything such as a baby aspirin, but we just call it that because it's small. In the elderly, we risk, since it's a gastric irritant, you risk GI bleed. Not just in the elderly. People who have ulcers should not take it. People with any other sort of problem, gastric problem with the stomach, probably shouldn't be taking aspirin. But anytime you do, you should take it with food and lots of water. The other non-steroidal anti-inflammatories, theoretically are better tolerated than aspirin. Problem is that's a bit of a propaganda. With respect to ibuprofen, ibuprofen is actually harder on stomachs than aspirin. It's more of a gastric irritant. So ibuprofen is another drug that should never be taken without food, even the 200 milligram size. The others, such as naproxen, it is a stronger gastric irritant than aspirin. It's worse than aspirin. Yeah, yeah. If you take an ibuprofen on an empty stomach, I did that. It works. Yeah, yeah. Yeah, yeah. Well, they all have aspirin in them, and aspirin is a gastric irritant. So you should probably um, you should probably be taking something. I mean, as little as a couple of soda crackers. What you want to do is raise the level of stomach acid. So the stomach acid, when your stomach is producing acid, it also has a mucus, puts a layer of mucus around the stomach lining to protect the stomach tissues. And so if you eat some food and the stomach starts producing acid and then puts this protective mechanism in place, then it's a lot safer for your drugs. Juice is okay I can't think of anyone that isn't. Juice, if you're taking it with juice, you probably are generating some stomach acid and some protection. It might be enough. The stuff in there that, you know, the problem is that with many of these things, what you have is a chemical mimic that gives you the flavor, and I'm not sure how much how much that's going to do the same thing. Although it may very well, the stomach may interpret that as something to generate some acid. When my daughter is taking ibuprofen for menstrual cramps, we've encouraged her to either eat a couple of almonds or a couple of soda crackers, something along those lines, something to tell the stomach, okay, you've got food to digest, and it starts generating acid. So it's a protective mechanism. If you do take one of these drugs on a completely empty stomach, you may or may not have a sensation of a stomach ache. Pardon? Yeah. I mean, that's the sensation when you feel when the stomach is being damaged by these things. The sensation that the stomach gets is like a stomach ache. Well, my daughter does well with 200 milligrams. So, for ibuprofen, for aspirin, if you were taking aspirin or Midol or one of those, um, what you have to do is see what works for you. And of course, these things don't stop the cramping. What they do is they stop the pain that's associated with the cramping, because the cramping has a physiological function. Okay. So it is something that you have to deal with, but you don't have to have the pain. Okay. So these things, some of the NSAIDs that we have are better tolerated than aspirin or ibuprofen. Some of the others, like naproxen and diclofenac. However, they have other side effects, and they're more expensive usually. So again, what they do is inhibit platelet aggregation. They make platelets slipperier, and then as a result of that, prolonged bleeding time. So you have, and what I'm referring to is it increases your INR. So it changes the way the body heals an injury. So it changes the clotting factors. Again, we treat these things. We have to be kind of careful. Ibuprofen is probably one of the most used drugs around, and we use it for moderate pain, arthritis pain, and it was originally developed as an anti-inflammatory for treating arthritis. And it was a prescription-only drug because the potency was 800 milligrams. Then we found out that it actually has some effects on kidneys and long-term use. We don't know what long-term use of low dose will do to kidneys, but my bias, of course, is that don't use them unless you need them anyway. So you don't just take drugs because they're there, unless it's actually prescribed. Taking aspirin, small aspirin or a full aspirin to prevent myocardial infarction in an adult is something that has been proven to reduce morbidity and mortality. So that's a slightly different topic in that respect. So the problem with all of these is, again, nausea. That's another thing that you might feel if you take it on an empty stomach. Ulcers, stomach ache, and something that gets interpreted as heartburn. It's acid reflux kind of thing. So we really want to be careful with these drugs. I'm a great believer in being careful with every drug, but understand that if you're taking it, you should always take it these things should be short term. You should never take any of these over-the-counter medicines regularly without the advice of a physician. So the other drugs, a drug that was developed in the, I think, 50s, Indocin, also known as indomethacin, not sold under the name Indocin anymore because it's a generic drug. It has been used. The place I've seen it most effective is in treatment of gout. And that's where I see it as something very, very different than some of the other drugs. Many of the other drugs, ibuprofen and aspirin and Tylenol and so forth, have very little effect on the symptoms of gout. Gout is a disease that is characterized by extreme pain. It's a buildup of uric acid crystals in the joints. It's like putting sand into your joints. And you can imagine that would be very painful. And most of the time we think about gout as something that appears, that red wine drinkers get, and it's in their big toes. That's not true. It can be in any joint in the body. My brother-in-law has flares of gout in his wrists to the point that he can't function, he can't drive. So, and he's been put back on indomethacin as a treatment for that, and a couple of other drugs. We use Xyloprim for that as well. Again, not a pleasant drug. It's rough on the stomach. So we want to take it with food. Common effects are ulcers and nausea and vomiting. And the nausea and vomiting are the stomach's response to an irritant. It wants to get rid of it. Remember, the body doesn't like foreign substances. The stomach is there to process food, which one could argue is a foreign substance when it goes in, but it gets broken down into useful components, and then the non-useful are simply flushed through the colon or get thrown out through the kidney. But when it's something like a drug or an overdose of alcohol, the stomach wants to get rid of it. The cyclooxygenase inhibitors, as I said, they inhibit prostaglandin. They have fewer of the GI issues, and they were originally approved for treating arthritis, but several of them have been removed from the market because of an increased risk of heart attack and stroke. And since this slideshow was prepared, I think all of them are now gone, and we don't use those. It has other effects. These drugs have other effects as well. That is basically makes them not a first-line therapy. We kept Celebrex on the market because there are patients who actually need these drugs. But I think now we have other substitutes that have allowed us to finally get rid of those, get rid of the last one. Tylenol, acetaminophen, also abbreviated APAP, APAP, by the pharmacy professionals. Since it is only an analgesic and antipyretic and not an anti-inflammatory, it has nothing to do with the prostaglandin sequence. We don't know how it works. And this is another example that people don't necessarily understand. The FDA doesn't care how drugs work. There's a scientific curiosity, and they'll often ask the question, how does this work? But the law does not require that we understand that a drug works. We only have to be able to demonstrate that it is safe and effective. Tylenol does not have the stomach problems of the rest of these drugs, but it can cause acute liver damage and even liver failure, especially in people who drink large amounts of alcohol, relatively large, and that is not necessarily an alcoholic, not a regular drinker, but one method of one way of actually causing many problems, including death, is to drink a lot of alcohol and then take a lot of Tylenol. Because it will destroy the liver. Okay, let's take our second break. All right, we're going to talk about opioid analgesics now. Opioids are any drug that binds to the various opioid receptors in the CNS. They also, by definition, have to be antagonized or blocked by naloxone, which is itself an addictive drug. There are three different opioid receptors in the brain, and we call them delta, kappa, and mu. And they appear to have slightly different functions. And for a long time, there was a theory that if you could selectively block one of those, you could have you could have analgesia without the addictive effects or potentially without the highs that you can get from some of these opioids. We have yet to prove that. I know of several companies actually that were founded in the 90s for that exact purpose, and every single one of them today is out of business because they couldn't ever get anywhere with it. So we have another thing, opioids. Opiates themselves are drugs that are derived from opium itself. And opium is a natural product of the poppy plant, the opium poppy, which is the largest cash crop in places like Afghanistan. And these are opiates are things that are part of this opium mixture. Opium has been an important product around the world for many years. Opium, the ability of the opium poppy to induce a euphoric kind of state when smoking was known since ancient times. And opium itself became a major product that helped build the British Empire in the 19th century. Was actually when the Emperor of China tried to stop opium trade in the middle of the 19th century, it set off 2 wars with Britain that prevented the emperor from stopping the opium trade because the British Empire was making a fortune on opium. And so that became such a problem that opium was a major issue in London, in England, during the Victorian era, at the late 19th and very beginning of the 20th century, to the point that, and it was acknowledged, to the point that Sir Arthur Conan Doyle, when he was writing his stories about Sherlock Holmes, Holmes was an opium addict. When he wasn't working on a case, he was sitting in his house smoking opium. So it was a major scourge and led to laws banning it. But having let that genie out of the bottle, we have not been able to contain it since. Opium itself is a major cash crop around the world. And arguably, you could understand why some people would be tempted to go ahead and produce it because that's what they can easily grow. Opium poppies grow quite well. Opium poppies are different than the poppies we buy here in the United States, by the way. That's because of the drug test itself, not because of the stuff in the seeds is not going to get you high. But the way the drug test works, they're looking at something that is in the poppy itself, and I'm not sure we haven't improved that test so that we don't take people that are otherwise innocent and brand them as using drugs. But be aware that there are many things. I mean, people that smoke marijuana, the test for marijuana is a urine test. And the problem is it stays in your system for long periods of time and can be detected. And although it is legal here in Colorado, a lot of employers won't take someone who tests positive. So you want to be careful with that. Anyway, narcotics is a term we use for drugs that are either directly derived from opium or derived from compounds that are like opium, synthetic compounds. These things have potent analgesic effects, and unfortunately, these are associated with mood alterations and behavioral alterations, and they all have the potential for dependence, tolerance, addiction. We'll talk about a few of these in a second. They're very, where do they come from? The bulb of the poppy, after it matures, the petals fall off, and then the seed pod matures. And then at that point, after the petals fall off, that's when it's ready for harvesting. In the picture here, the opium gum, there's so much of it in there that it's leaking out of the bulb. And then we process that into morphine. We further process it and chemically modify it to make heroin. It was first isolated, morphine was first isolated in 1803 and named after the Greek god of dreams, Morpheus, because it was a potent painkiller. During our Civil War, we had during the American Civil War, we had no anesthesia. Anesthesia was just coming into being understood, and actually being resurrected from the past. The Islamic world and physicians in the Islamic world had anesthesia in the 10th century, but that was all lost. It wasn't until the late 19th century that we began to use things like ether and chloroform. But during our Civil War, there were a lot of the weaponry used was pretty nasty, and there were a lot of amputations necessary in field hospitals. And basically the only thing they had was they could get you drunk. And that was quite often what was done. You'd get someone drunk enough to pass out and then operate on them. But in order to overcome the pain, they were given opium or given morphine. And at the end of the Civil War, we had tens of thousands of morphine addicts at that time. This is a part of our history that we don't discuss very much. But what comes out, what are the opioid analgesics? Well, codeine, methadone, morphine. Morphine sulfate is often abbreviated MS. Hydromorphone, which is a derivative of morphine. Fentanyl, oxycodone, hydrocodone, which are both of those are derivatives of codeine. Besides hydromorphone, we have oxymorphone. This is a short list. The list of these things is very long. All of them are controlled substances. Many of them, such as hydromorphone, oxycodone, hydrocodone, were developed early in the 20th century in an attempt to find a non-addictive morphine. In all cases, they failed. More recently, we have tramadol that was being touted as a non-addictive opiate receptor blocker. Lately, the amount of information it's being contested strongly by the pharmaceutical industry, of course, but a huge amount of information is available that indicates that, once again, our attempts at finding a non-addictive opiate receptor blocker have failed, because I've heard from I've heard from a number of people that tramadol actually has an addiction potential. We're still trying to find the holy grail of analgesia is finding an opiate receptor blocker that does not have at least the addiction potential. One of the problems with the addiction of the drug is addiction is a multifaceted problem. We can develop physical dependence, which means that we need the drug in order to get through life. We also develop a psychological dependence on the high that it gives you, and that's been difficult. So what they do is they bind to receptors on the various fibers, the nerve fibers, and then they prevent the opening of the gate. We talked about what the gate was. So the impulse transmission theoretically does not get to the brain. We use them for mainly to alleviate moderate to severe pain. They can also be used, as in codeine, as a cough suppressant. Side effects, well, there's the euphoria. There is nausea and vomiting. There is respiratory depression. This is what actually is the cause of death in overdose, is depression of the respiratory system. Urinary retention, diaphoresis, sweating, and flushing, pupil constriction, and constipation is also a major issue because it shuts down peristalsis, or at least partially shuts down peristalsis. All of these things have essentially the same set of problems. Most of them are themselves Schedule II controlled substances. Codeine is often in combination with acetaminophen. Small doses of codeine in combination with acetaminophen are Schedule III. That's the Tylenol plus codeine products. They're dose-related response. So the more drug you get, the more analgesia you get. Unfortunately, the more you get also the respiratory depression. Tolerance is developed. When you start developing tolerance, you need more and more drug. One of our issues is we used to actually think that if you were in really intractable, severe pain, you wouldn't get addicted to these drugs. That's not true. Not true at all. The drugs themselves are fairly easy to come by. They're fairly they have other kinds of uses, but the side effects and the pain are the main reduced usage. Codeine is produced from morphine, so codeine is something that we can take and make using morphine. Again, codeine was originally looked at as a dental anesthetic, and it was used for a while in that. It has a little different profile. It is not, the analgesia is not dose related. Also, it is a sedative, which is not what we necessarily want. When it's administered itself, it's a Schedule II It is has somewhat less side effects, but the problem is people become allergic to it much faster. Hydrocodone is one of the most common. Hydrocodone was for years, um, um, when it was mixed with acetaminophen or ibuprofen and other things, was a Schedule III controlled substance. Several years ago, about 3 years ago now, it was upgraded to a Schedule II controlled substance because large amounts of these drugs were being prescribed. Schedule II has limits. It has already been changed as opposed to what's on this particular PowerPoint. Schedule II has limits on the number of prescriptions a person can get, on the number of doses in any prescription, and the number of doses in any month, any period of time. Also, Schedule II, you cannot refill. So if you are being given a Schedule II controlled substance, not only can it not be refilled and you have to have a fresh prescription every time, these prescriptions cannot be called in. There isn't a provision for emergency use, but there's a limit. You can only have a couple of days of drug without having to get a paper prescription. So the drug itself has been extensively used. The VA used to send out bottles of 1,000 to its patients. They are not doing that anymore, or at least they're not supposed to be. And so it was a great way to create quite a street market for these drugs. Again, works pretty well, but they're nasty drugs. Oxycodone, known as OxyContin, is a different derivative of codeine. It's very addictive. It's always been a Schedule II substance, and it does like any of these. We don't want the patients drinking alcohol mixed in with this. Alcohol is a CNS depressant. Mix that in with the respiratory depressant activity of these drugs, and you've got a real mess. Fentanyl. Pardon? Fentanyl, yeah. No, what I just talked about was OxyContin. No, fentanyl. Fentanyl is how I pronounce it. Having been in the pharmaceutical industry for a long time, I know the general pronunciation rules. They get broken as often as they get adhered to. But fentanyl, as a lot of people call it that, but it is but fentanyl would be a different drug than fentanyl. Okay, from a chemist's standpoint. Okay, this one is synthetic. It's probably the most potent. Yeah, and it is also the deadliest. Yeah. Yeah. That's okay. Yeah. Well, that's pretty nasty pain in and of itself. Yeah, my wife definitely does.
By the time I was forcing, I had dilated. They had me walk around. I still didn't really feel any bad contractions when they started pumping drugs. So.
Yeah, I don't know. Was the fetus stressed?
My water broke. So that's why I had to stay in the hospital 18.5 hours waiting for him. Yeah. I mean, I wasn't stressed. I wasn't in too much. I didn't have back labor or anything. So I just,
I get, you know, I guess I really, problem is babies come when they're ready,
yeah.
and we intervene too much in that process. And the baby signals the body when it's time to be born. Now, various things can happen. Pardon?
I don't think it was the, my UI, and for 7.5 months, almost the time I was pregnant, when we got home. The night before my water broke, and, I'm pretty sure we broke it. Because I sat up in bed in the morning to get ready to take me to work, and yeah, my water broke. And I thought it was time, but I got there and they're like, you're only 1 centimeter dilated. And I'm like, oh,
Uh-huh. Well, yeah, that's a tough place to
so
be.
maybe it was when I got up, the way I got up off it,
Maybe.
because he was born a month
Mm,
early, or
yeah.
like 3.5 weeks, 4 months.
How big?
He was 6.4 pounds and 19 inches long, so it would have been a lot bigger.
Yeah, our second child was born 7 weeks early, and she was still 4 pounds 12.
Yeah,
So she would have been bigger than her older sister, who was 8'12" when she was born 10 days late. Yeah, Braxton Hicks. Yeah.
They thought
Yeah.
instead of him being in the NICU, he comes to steroid shot. His lungs would be and I was only in the hospital for 2 days. So I was done. I was like, can I just go home?
Did they do a C-section, or was it natural
It was
birth?
natural.
Okay. Well, yeah, I've seen too much intervention and the side effects on kids.
Yeah.
And I've also seen too many doctors who, well, I'm going on vacation, so let's just have this baby, and they induce labor. And at that point, I would say, let's get a new doctor. Because, then, one of your partners or one of your friends can be available if we need them. Go on your vacation. But yeah, we have a cousin who was in an induced birth, and they got the date wrong because she's never been right. I mean, there's nothing physically wrong with her, but the way she thinks is just off the walls sometimes. Yeah, she's very smart, very intelligent, and she can't get a joke.
Oh.
I mean, she just doesn't get them. Everybody's laughing, and she's saying, "Why is that funny?" Okay,
Yeah.
but I mean, things do happen, But
Yeah, I
anyway,
didn't try to
well, that's
my water broke. I had to,
yeah, that's kind of bad. We before our second child was born, we had a water leakage, and what we figured was it was a high tear,
yeah.
and we figured it was the baby just trying to kick her way out, because she never liked to be bundled or anything, none of that stuff. But we figured that she actually induced that because of the probable location. And then we were sent home and told, you will not do anything. You will stay in bed. You can get up while Mike is at work and microwave a meal, and then you'll go back to bed. And then 3 days later, she decided to be born anyway. So that was exciting. It was real exciting to be driving at about 85 miles an hour across town twice in 3 days. and not getting caught by the cops. We got lucky, but yeah. Anyway, pardon? I said, my wife is about to give birth. And then the cop says, follow me, is what they say. Yeah, yeah. Or they'll call an ambulance. But, you know, if they're likely to take a look and yeah, sure. I was willing to take that. Yeah. Yeah, they will. Yeah. Depending on where you are, you know, they might just say, you know, follow me, and you take off. And then you get your ticket at the hospital, you know. But as I say, I don't care. I was more worried about, you know, my baby. Actually, cops have given. There were several cases when we lived in North Carolina where cops would pull someone over who was about to give birth, and they'd have to assist, and then they'd call the ambulance. Well, it happens. Yeah. Yeah. Anyway, fentanyl. It's a very dangerous drug. It theoretically has similar activity to others, but my understanding is that it's the most potent of the analgesics. As a result, it also is the most dangerous. It is usually used for you know, sort of after surgery. We have both injectable form and a patch form. We have to be careful with patches because what happens, what has been a number of cases of people who take the patches off a patient, and then addicts who are working in the medical field, and unfortunately there are a few of those, will take the patches off the patients and suck the fentanyl out, and altogether too often they're dead. Methadone is used for treating. It's a synthetic opiate that's used to treat. It can be used for pain, but it also is used to treat opium or opioid addictions. Tramadol theoretically was not when it was first marketed, was not a controlled substance. It's a centrally acting drug, which was being touted as not being addictive because it had very low affinity for the opioid receptors. But you know, there were several other mechanisms by which it worked, and was used a lot of times. It's used for neuropathic pain. It's also used post-operatively. However, it is now a controlled substance. I think it's Schedule 3. And there are some of us that believe it probably should be Schedule 2. The antagonists, like naloxone and naltrexone, are used to reverse the opiate-induced respiratory depression. They bind to the opiate receptors and prevent the drug from the opiate from activating those receptors. There's been some talk here in town, I don't know if you've followed any of this, about training. There's been a lot of talk about the police carrying naloxone, Narcan, to use on opiate overdoses that they run across. There's also talk on campus here, at CSU campus, about equipping dormitory resident advisors, or the students that are the RAs in dorms, giving them naloxone. And there's a lot of controversy about that. You do need to be trained so that you can, you need to be trained in how to recognize the symptoms of opiate overdose, and in the use of the drug. So it does not itself have the properties of an opioid, but it could induce withdrawal from long-term addicts. Tolerance is common. And what this means is that ever-increasing doses are needed. There is a physical dependence that is natural, and it has to be, the body is adapting to the presence of the opioids. The psychological dependence is the addiction. The physical dependence is characteristic of the tolerance. The problem is we need to be able to deal with both tolerance and physical dependence, because they are common. The tolerance and physical dependence are different from the addiction side, the psychological dependence. And we have to balance our treatment with this. Let's see. What happens with physical dependence is that we get withdrawal. We get the usual sweats and shakes and everything else that come with withdrawal from almost anything that we have become physically dependent on. We can have all sorts of symptoms, including psychological symptoms. Okay, so it's now 11:30. Let's take our last break. Okay, so since pain is something you'll be dealing with if you're working in almost all clinics with some of your patients, there's a couple of things that we should talk about. One is to do a good pain assessment on the patient, including where the pain is, where in their bodies, what kind is it? Sharp, dull, achy? Does it feel like somebody's trying to poke a knife into them? That sort of thing. Constant, intermittent, is how long they've had it, what they're taking for it, what they do to relieve it, because there's lots of things people try to do to relieve pain. Sometimes exercise, depends on what kind of pain it is. Acupuncture is something people will use, and then self-medication, alcohol, meaning in this case the negative self-medication, alcohol and illicit drugs. What you want to try and do is assess with them what is going on, and in fact, there's a movement to have that as the fifth vital sign. Here in this PowerPoint, they give us some assessment tools, and I have a problem with the way this tool is set up. I was talking before you came in, Glennis, I was talking to Cheyenne about the tools, the 1 to 10 scale, where 0 and 1 is no pain and 10 is really severe pain. These things end up with the worst pain possible. The problem is people can imagine it. My wife had a patient one time who clearly was in very great pain, but when she was asked what her pain level was on the 1 to 10 scale, would say 3, and it was obvious to my wife that should have been much higher. And she had been told that 10 was the worst pain imaginable. And for her, the worst pain imaginable is feeling someone trying to saw off an arm with a butter knife. Well, that's not good. And these things are not absolute. Pain scales should always be relative to the patient. In this particular case, I disagree with the worst possible, and think that this should be the worst pain you've ever felt. Okay. So I would urge you, if you are doing a pain assessment, to look at it from that standpoint, the worst pain you've ever felt as being the top of the scale. Now they use these Lego and this universal pain assessment that uses something related to emoticons. And it does work, but just be careful what you're doing. Also, pain control is about prevention more than relief. I mean, yeah, you have a headache, you're going to take an aspirin or an ibuprofen to get relief from the headache. But if you are in a position to know that pain is a likely event, or pain is increasing, then before it really gets severe, you should try to manage that, including both pharmacologic and other approaches. Being aware of the side effects of the drugs should be a part of the discussion with the patient. But patients also should be warned not to take any other medications or OTC, even OTC drugs, without consultation with the physician, because of the side effects and the drug interactions. Patients don't understand those, and even doctors don't, but all right. But then we need to be monitoring whether it's working. If it's not working, then something else needs to be done. And how do we know the effects? Well, the pain itself is more tolerable. We have a better attitude. Pain is very debilitating. A person who is in pain often has problems with their ADLs, their activities of daily living, and they find it difficult to cope, and so they end up taking more drugs. One of the issues with the opiates is you've probably been hearing that we have an epidemic of opiate abuse in the country. Well, we also have an epidemic of opiate deaths. There was something like 63,000 opiate deaths last year in this country, which makes it one of the leading causes. And who are the people taking these drugs? Well, we're not talking about the street people, the ones we normally think about, who are the drug addicts, people that are on the bottom end of our society. We're talking about people in my age group. Many people.
She's younger than my grandma, so I think she's like 75 or something like that. Yeah, my grandma takes a lot for pain. You're biking, you're Tylenol, constantly taking something.
Yeah. There can be reasons that she's in pain, or it may be that this is just her coping mechanism for anything that comes along. The issue with pain control, of course, is that it's always individual, and it's always difficult. But what we're looking for is with this is to try and find a relief. There is right now that, oh, you hurt, here take some drugs. Well, okay, why do you hurt? What is, giving people to pain is a symptom. It's not a sign because we can't measure it, but it is a symptom, and it's part of the complex of a number of diseases. And the problem is, as we get older, we hurt. Our muscles don't work as well as they used to. Our joints are deteriorating. We have, whatever our style of life has been, ultimately is affecting how we age and how we respond. Those who have had a fairly active, healthy lifestyle usually do better, but that doesn't mean they're not going to have things like arthritis, which is, there is some indication that things like that run in families. But the issue with pain is that it's a signal that something isn't right, and just throwing drugs at it is not solving the problem. And that's been it. There's a tremendous a body of information now that that tells us that these things just don't work. There was a study that was published not too long ago about comparing non-steroidal anti-inflammatories, the ibuprofens, etc., with opiates for control of pain in chronic pain. And the result of that study was that the opiates are no better than the non-steroidal anti-inflammatories at pain control. So the question is, if that's the case, why do we want to be taking these things? People that have severe arthritis, that have degenerative bone disease, that have lots of problems in their in their diseases with pain, have been given these drugs, and that's all they're being given. And as a result, they have become dependent on them. Addiction among older Americans is rising rapidly. Deaths from overdose have also been rising rapidly. So there is a great need in medicine for something to replace these drugs with. And the problem is we don't have it. There is, and I can't believe that there isn't a lot of research going on. I don't know exactly what it is, because since I've been out of the pharmaceutical industry for a while, I haven't been following what's been going on. It's not so easy because, of course, it's all secret. But nonetheless, you don't hear a lot about breakthroughs in pain control. What we see is people saying, well, you need to exercise more. You need to modify your diet. Lots of supplements are given that are supposed to reduce joint pain, etc. They variably work. Acupuncture is used. There are some approaches that involve things like hypnosis. Remember, pain is perception as well. So if we can change perception, we can modify that pain response. However, they don't all work, and we need a lot more. But the thing to remember is that for chronic pain, the data are now telling us that opiates are no more effective than non-steroidal anti-inflammatories. So perhaps there needs to be more use of some of the more potent. Now, but they also have side effects. Some of them are pretty severe. So again, patient dependent, what works? But why not try naproxen if you're not getting a whole lot of relief from ibuprofen? Why not try diclofenac, meloxicam? Why not try these drugs and see if they help? But a lot of it has to do with opiates are big business. The companies that make them make a lot of money on them, and unfortunately, in this society, money is important, and money talks. So we'll have to see what comes on. But pain is a difficult topic. Pain is, okay. Pain is one of those things that you'll see a lot of. Probably, I would guess, as our society ages, it's going to be number 2 after infectious disease, or maybe number 3 after infectious disease and cardiovascular problems. But nonetheless, the issue is that it's a normal part, apparently, of aging, that we begin to deteriorate, and we get a little more pain and a little more pain, and all we can do is try and deal with it, one way or the other. But pain management strategies are important to understand. Okay. So questions, comments? Okay. Mm-hmm. Yeah. I wanted to mention that the discussion post last week. Everybody went from antibiotics to not everybody, but a couple of you went from antibiotics to opiates, painkillers, and that's not really what it was about. The issue is, why do we have what's wrong with overprescribing antibiotics? And yeah, well, that's because there's a lot of information now about the overuse of painkillers. And that, unfortunately, sort of dilutes the argument about overuse of antibiotics. But the overuse of antibiotics is why we have so many resistant organisms now. And there's some great concern worldwide about these resistant organisms. Because if we can't treat these organisms, then they can become major problems. We're already seeing it with things like tuberculosis, and we need to, and because we're now seeing strains of tuberculosis that are not treatable by any antibiotics, and that's a little scary. It goes back to the days when tuberculosis had no treatment, and tuberculosis is kind of interesting. I mean, tuberculosis has been with us for millennia. We've seen evidence in mummy skeletons from ancient Egypt. King Tut had spinal tuberculosis. So why haven't we developed an immunity to that disease? Why are our immune systems not more vigilant about that disease? And there are lots of reasons for that, but nonetheless, it does We've had plagues in the past that would kill a very large percentage of the populations, and yet they're not a major problem today. So obviously we have some sort of mechanism for control. So why is it that we have some of these? And part of the problem is that they've always been with us. They've been part of the things that have killed us. And it's only been in the last 100 years that we've developed strategies for and the ability to prevent those deaths. And so it's only been in the last 100 years that we've had the potential for developing these resistant organisms. So. All right. Questions? Okay. Well, we still have about 15 minutes of class left, so I just want you to catch up on some of your work. Remember that you can repeat the quizzes. Yeah, quiz 3. I renamed it quiz 3 because it was a little confusing to call it quiz 2, and it's in week 3. What I want you to do is do some of your work while we're here for the rest of the class, and then at 12:30 we'll break because I have to get ready for my next class. And I will. Okay, so just print it out and give it to me. Yeah. Yeah, no, just go ahead and print it out and submit it and hand it to me. That's fine. And that would be after the class, after you present it on Monday. Okay. And let's see. And next week, you'll have your drug class oral presentation as well. You'll have, we'll talk a little about the reproductive system and drugs that affect that, and the endocrine system and drugs that affect that, as well as GI. So it'll be a very rough overview of those areas. And Sarai, I hope you have a chance to watch this video, just send me a note saying that you did. So I'm going to stop the recording now.